Assalamualaikum. Good morning, everyone. It is my pleasure today to start and introduce our distinguished speaker this morning, my radiology colleague who has just joined us officially last year as our clinical radiologist and academic lecturer. So I would like to introduce today Dr. Wong, who is our clinical radiologist. She has special interest in breast imaging as well as neuroimaging. So she is highly motivated, and she was also our master's alumni, radiology in University Malaya, and she specializes in general radiology with special interest in breast imaging and academic research. So it is my pleasure today to introduce Dr. Wong, who will present her special interest, who completed dissertation of a breast MRI in abbreviated and ultrafast imaging. So without wasting any more time, I would like to open the floor to Dr. Voon, who's going to present today the topic of future of breast screening isn't slower, it's ultra-fast, a real-world perspective from University Malaya Medical Center. I would like to pass the floor to you, Dr. Wong. Thank you very much.
Thank you so much, Prof. Kat, for the kind introduction. This morning, I'm going to talk about breast MRI, and my presentation topic is the future of breast screening isn't slower, it's ultra-fast, a real-world perspective from our center, University Malaya Medical Center. Just a little bit background about breast cancer. Breast cancer is the most common cancer among women in Malaysia, affecting 1 in 19 women, making early detection critical. It is also listed among the top 10 causes of death in women, according to the Department of Statistics Malaysia 2025. These numbers are alarming, and they remind us that early detection is key. Screening is our first line of defense, but as many of you know, conventional methods have limitations. Breast MRI is already an important tool in screening today, particularly for high-risk patients such as BRCA mutation carriers, women with dense breasts, and increasingly in patients with breast filler injections where conventional imaging can be limited. In 2025 alone, UMMC has performed 109 MRI breast scans, reflecting the growing demand for this modality. However, we all know the challenges. MRI is time-consuming, costly, and not easily accessible to all patients. At our center, we started exploring ultra-fast breast MRI back in 2020. That was during the COVID period. Our early research showed promising results, particularly in terms of improving efficiency while maintaining diagnostic performance. Since then, we have increasingly incorporated ultra-fast sequences in our breast MRI practice, including in the screening setting. So the question becomes, can we make breast MRI not just accurate, but also faster and more scalable? And what is ultra-fast breast MRI? It is a high temporal resolution MRI that captures the very first seconds of contrast enhancement in the breast after injection, contrast injection. Unlike conventional MRI, which images every 60 to 120 seconds, ultra-fast MRI acquires images every 2 to 10 seconds, effectively producing a video of how quickly lesions take up contrast. This early enhancement reflects tumor muscularity and angiogenesis, helping to distinguish benign from malignant lesions and potentially improving specificity. It was very first published in 2013 by Wong et al. With the title of Ultra-Fast Dynamic Contrast Enhanced MRI of the Breast Initial Clinical Experience. They demonstrated that early contrast kinetics could help differentiate malignant from benign lesions, providing a foundation for the ultra-fast protocols used today. And this is a figure that demonstrates the overview of the ultra-fast sequence in relation to the standard sequence. We can see that this is the standard sequence, which takes 360 seconds from pre-contrast first second until the delayed phase. However, for ultra-fast, we take only 20 frames from the whole standard sequence, 1, which is the pre-contrast, and 19 frames, which is the first post-contrast. And that makes up the 20 frames of the ultra-fast sequence. This is the standard breast MRI kinetic curve, and this is a comparison with between the standard with the ultrafast. For the standard, what we measure the overall contrast uptake over the span of few minutes. It usually has 3 to 6 post-contrast phases taken every 60 to 120 seconds. And the curve, they are divided into type 1 curve, type 1, which is the one that goes continuously enhances, type 2 curve, which plateaus, type 3 curves, which shows wash out. And the purpose of the standard kinetic curve is to classify the lesions according to Barrett's kinetics. It helps to differentiate between benign and malignant, but the temporal resolution is limited. In comparison, ultrafast focuses the first second of the contrast uptake, usually 2 to 10 seconds per image. It calculates the maximum slope of signal intensity versus the time. So this is the time, and this is the signal intensity. So the steeper the initial slope, it has tendency of showing malignant lesions as compared to benign lesions. They capture the very early vascularity and perfusion, which standard MRI might miss. So graphically, X is the time, Y is the signal intensity. And they also have a different type of curves. Type 1 curve, which is less than 6.4%, it shows that cancer is unlikely. Type 2, between 6.4% to 13.3% per second, shows cancer is equivocal, whereas type 3 is more than 30.3% per second, which shows that cancer is very likely more than 85%. And this is adapted from Mann et al.'s paper as well. So this is a video of ultrafast. In the short 80 seconds, we can start seeing how beautifully the lesion is enhancing, and you can see the surrounding vascularity as well. I'll just play one more time. So after the aorta enhances, you can start seeing the lesion start enhancing very well with the angiogenesis. Okay, and from the lesion, this is the software that automatically calculates the maximum slope. We just need to draw a region of interest at the lesion, and this slope is generated. And from here, we can calculate. So you take 210 minus 60, it gives you 150 over the time span of 35 to 52. That divides by 17 seconds. So they give us to 8.8% over S per second, which is a maximum slope type 2, which is cancer equivocal. And this lesion proven to be cancer. This is a table that summarizes the difference between the standard MRI protocol and the ultrafast MRI. So both, they have their strength and their limitation. For standard, their strength is it has its established Barrett's kinetic patterns, but it can miss very fast initial enhancement. As compared to ultrafast MRI, they detect very subtle differences in very early enhancement, but there's less information about the late phase and washout. I'm just going to show a few real-life cases that derive from UMMC patients. This is the first case of a left breast cancer with bilateral axillary lymphadenopathy. So this case is almost similar like the first video that I've showed. You can see the left breast cancer. It lights up very quickly right after the aorta and the vessels have enhances. And then it also shows bilateral breast vascularity, and can see enlarged lymph nodes on both sides, left side more than the right side. This is the second case which showed a bilateral dense breast. We can see that this dense fibroglandular tissue appears quite dense. This is one of the examples that shows that ultrafast can show early screening, show screening in patients with dense breasts. So you see the heart and aorta start enhancing, no focal enhancing lesion seen. So this is a normal breast MRI in a patient with dense breast. This is more interesting. This is a patient with bilateral breast filler injections. Let me just play the video first. We can see the fibroglandular tissue in both breasts. They are quite dense as well. Left side more than right side, but there's no enhancing lesion seen. But this is a T2 weighted stir. We show that we have multiple T2 weighted cystic lesion seen in of varying sizes distributed in both breasts. There's also subcutaneous edema. You can see all these filler injections. They are scattered everywhere. Some of them are also seen in the pectoralis major muscles. And these filler injections, they can limit the screening methods such as mammogram and ultrasound. Essentially, the most sensitive or the most helpful modality in patients with breast filler injections will be MRI breast. In short, standard MRI breasts, they show overall enhancement over minutes, good for morphology and late kinetics, whereas ultrafast MRI, they captures the very early contrast inflow rate, may improve specificity and reduce false positives. In 2023, we published our study on ultrafast breast MRI in 54 patients with suspicious lesions. The protocol successfully detected all malignant lesions, and the maximum slope of early enhancement was significantly higher in cancers than benign lesions, which is 13.7% per second versus 5.45% per second. This result showed that ultrafast MRI can accurately differentiate malignant from benign lesions, making it a promising tool for breast screening. This is the results from our study. We are comparing the sensitivity, specificity, accuracy between kinetic curve of standard MRI breast and the maximum slope of ultrafast MRI. For the standard MRI, they showed higher sensitivity, which detects almost all cancers, but more false positive. However, ultrafast MRI showed slightly lower sensitivity, but higher specificity. It is better at ruling out benign lesions. In short, ultrafast MRI balances speed, accuracy, and reduce unnecessary biopsies. In conclusion, ultrafast breast MRI is a transforming breast imaging, delivering faster scans, higher specificity, and confident early lesion characterization. At our center, it is enhancing efficiency, reducing unnecessary interventions, and improving patient outcomes. This is progress with purpose, and with tools like this, we move closer to stopping breast cancer. These are my references. Thank you very much for listening.
Thank you so much, Dr. Wong Voon, for the very enlightening and comprehensive presentation, albeit very short. Anyway, I don't think there are any questions. I would like to post a query for you. So with all the evidence that has come from the literature as well as the recent development of fast screening, non-invasive, non-ionizing radiation method, which is comparable to screening mammography. What recommendations do you have for Asian population, especially Malaysians who usually present with younger breast cancers as well as very dense breasts on mammography?
The screening protocol for ladies with dense breasts right now, it's above 40 years old. Once annually, one mammogram annually, or once in 2 years. But we are looking into advancing technology. We are looking into a better way of screening. And most ladies, they don't like the compression from the mammogram. And we are hoping that with ultra-fast, like a fast breast MRI like this could provide an alternative screening method for the populations. So with a screening method, faster screening method, hopefully lowering cost of screening as well, this will be more available to the Malaysian population.
Thank you very much, Dr. Wong. I don't see any other questions. Is there? Oh, chat, there is. No?
No.
All right. Okay. Do you have any last minute words or take home message for our audience today?
The only way to stop breast cancer is for early detection. And I hope that not that we are advocating the Malaysian population to do so, we ourselves setting the right examples to the rest. That's all from today.
Thank you very much from me as well.
Thank you.